Hey guys, Dr. Pelto here. Welcome to Podiatry Practice Mastery. We're trying to get your office to the 1 million mark. I want to share a little experience here. This was a talk I did to a local physical therapy place. As you can know, it's going to be a little funny. I'm joking a little bit around with them about a recent medical procedure I had. They're a good group. I send most of my referrals to them. I gave them some guidance to sending more referrals of Shockwave and orthotics to me, kind of explaining that. So you can see there's going to be some rough parts in there with some problems, but I think you'll like the overall gist of this. So hope you enjoy it. Let me know. So those that aren't here, you don't get the free goodies, so I'm just going to make you salivate over what you're not getting. So we have a lot. If you want to come to my office, I'll give them to you. We have water bottles. These are the best socks ever. Okay. You can come to the office and just say hi to me, and I'll give you socks. Shoehorn. Books. Now, if you wanna have patients like have a second opinion with me, all you do is you don't, because it's kind of awkward to have that conversation. So what you just say, hey, we have a doctor that's you can say he's good looking if you want, but you can say he knows something and say he's got a book. We can give you that book, okay? And I think that's about it. That would be the easiest thing. Okay. Yes, you can get double the goods. You guys can get double the goods. I have my notes here. Are you guys recording this? Where is it recorded? Did you hit the record button? Okay.
If you wanted to present your screen.
Yeah, I'll present the screen in 1 second. Where I'm at here. Wow, can you guys see that? Is that going to be okay? Okay. So welcome. Thank you, John, for inviting me. Thank you for everyone that's here and everyone that's online. My name is Don Pelto. I'm going to do a poll. Okay. What has changed about me in the last 6 months? Those that can guess, and you can't say it, you might know. You guys can guess. I'm going to give you a special gift if you come to the office. There's something that changed. This is something left. This is non-professional stuff first, okay? What's changed? What you can see in the screen right now. What about my face? Not Botox. I didn't shave my beard. No. Anyone else can guess? No, I still fast. I haven't eaten yet. You're going to laugh. Glasses. No, I got new glasses. Something else. Something that involves going to Brazil for like a 12-hour procedure. Uh-huh. No, it's in my face. Nope, didn't get teeth whitening. Come on, you guys. There's not. I went to Brazil. My wife's from Brazil. We were in Brazil, and I said, honey, I'm going to do this. It was a type of cosmetic surgery. You're going to laugh. You're going to laugh when you hear it. Nope, not nose.
Hair transplant.
So if you go to, no, don't tell anyone. Okay, this is our little secret. I went to Brazil 6 months ago, and I got a hair transplant. So my wife says I look 15 years younger, so now I tell her she's married to a younger man. Okay? So if anyone wants to do it, don't go to Turkey, go to Brazil. Okay? That's all I have to say. So I had this anyway, you can look at the before and after videos if you want. If you want to know my doctor, I'll let you know. So I'm going to go over a few things. We're going to talk all about heel pain today. I like to have fun. I have fun in the practice. I have fun when I come different places. I'm going to start with some of my pet peeves because I feel like I have intimacy with you guys and I can tell you some of my physical therapy pet peeves, my frustrations, and then I'll talk a little bit about heel pain. My biggest pet peeve is that sometimes my patients will come to you without pain and you guys just say there's nothing you can do or I don't need to do anything. Okay. If there was nothing that you could do, I wouldn't send them here. And I'd like you to look away from the foot. Most of the time, I would prefer you to treat not the foot because you're always getting my patients after they've had foam rolling, night splint, morning stretch, 3 sessions of shockwave, maybe a cortisone injection. They're probably 80% there, okay? But what I want you to do is look at the hip. I want you to look at the core. I want you to look at their breathing. I want you to look at everything like that. And if you're good at explaining it, you'll probably get 6 weeks or more of physical therapy. Okay, so my biggest pet peeve is they come in, they're pain-free, and the physical therapist says, sorry, I can't do anything for you. Okay, that's my number one pet peeve, just trying to help you out, okay? Because I want you guys, we all need, like, you're into preventative. Like, if you can't find things for the rest of their life with physical therapy, you got something wrong, okay? Everyone has an abnormality somewhere. Watch them walk. I don't know how you guys do your things, but I trust you. Second thing is, when I tee them up, so they are getting a night splint for everyone that has Aquinas, and they're all getting foam rolling exercises and a morning stretch, okay? And then they come to you guys and you say, I want you to do stretching. Now, if they were going to do stretching, they could get stretching on the internet. If they, they're going to come for stretching, like I could teach them stretching, but you have to do something more than the internet can do them. That's the way I think about it. That's why the patients aren't coming in doing stretching. Like, they can do the runner's stretch, they can do the wall stretch, like those are all okay. But frankly, they're going to do that before they see me. And so when they come to see me, that's why everyone gets a foam roller or a trigger point ball or something else like that. So just kind of, so when they're going to come in, they're going to say, what's the doctor having you do? Well, I'm doing foam rolling. I'm doing probably a night splint. And then intermittently, they're going to do stretching. Okay. And so I'm just kind of instructing you that's kind of what I do. And then the last one is when patients come and say me and they're like, the PT didn't do anything, or I don't feel like I got any benefit from PT. And so what I would really want to encourage you, and I can't teach you guys how to do this, but patients need to feel value in the PT treatment. Otherwise, they're going to feel like they're wasting their time. And I can't teach you how to do that. Okay, just the same way you can't teach me my thing. But I trust that you guys can do that. If you can learn from more experienced PT, because you're always looking at other things. Like, I had a patient come in the other day, and they're like, wow, like it opened my whole world. He was talking about belly breathing. And they were talking about how my breathing affected everything else that's tight in my body. And I was just so amazed. So it's really teaching your patients. Okay. You're going to teach them about breathing. And I don't know how you guys do that, because I don't know that much about breathing. You're going to teach them about core instability. You're going to teach them about, when they had kids 10 years ago, how that affected everything. You're going to be teaching them about their neck pain or their back pain is coming from their foot. You're going to, all these other things, their pronation and the orthotics is going to help the other stuff, Anyway, so those are the thing. And then when you don't team up on the patient in terms of their shoes, I'm always mentioning shoes, but they don't listen to me. So I love it when you come in and you say, what did the doctor say about your shoes? Did he approve those shoes? And we're all sending them the same place. We're sending them to Sneakerama or Marathon Sports, but like team up on them with me. So I'm always bringing it up. And so today we're going to go over. So those are my main frustrations. That's it. But you guys do a great job. That's why I send pretty much all my patients here to see you. So I'm going to start by sharing my screen. If you guys have any comments, you can tell me. Okay. So I am going to share my window here. Dr. Stone, when she comes in, she might be here. I want to introduce her quickly. Dr. Stone is the newest doctor to our practice. There she is, Dr. Stone. Right on time. I'd like to introduce everyone to Dr. Stone.
Hi.
Dr. Vicky Stone. There you go. Dr. Stone is a biomechanics extraordinaire. So if you guys that's who I go to. Like, she takes Dr. Feldman's orthotics, sends them back and gets them fixed so they work with the patients. Okay. So
I don't know if Dr. Feldman's going to be happy.
I know, but he's not here. It doesn't matter. So she helps me with it. So she really likes gait evaluation, likes biomechanics, and she does a great job at that. So utmost respect for Dr. Stone. She's going to be talking to you, I think, next month more about that. But if you have like these hard biomechanical issues, that's what she really likes. Okay, so I'm going to start by sharing my screen. I'm going to give you guys a resource that you can use. So I'm going to share my window here. Okay, so I'm going to share something. I think I shared this last time. It's called my patient presentation tool. If you ever need to get access to it, you just go to drpelto.com, and that's our website. It's going to be switched over to this. And on the bottom of this website, all the way on the bottom, there's something that's called patient presentations. And so these are the presentations that I go over every single day with my patients. So if you want to know kind of what I'm talking about with my patients, this is what it is. And so what you're going to see here is an alphabetical listing, because I'm real simple. Like, it's also Achilles is first, AFO is second, bunions, cavus foot, cysts, diabetes, exostosis, Haglund's, hallux limitus, peroneal tendon problems, plantar fibroma, warts, and then down to wounds. So what these are, if you're kind of techie, is these are going to open up to Google Slides in full screen mode. So the reason it's full screen is so no one can steal these. Okay, so no one can, you guys can, I guess, cut and paste them if you want. If you want these, let me know. But I use this as a resource. So this is what I actually do with my patients. So they come in, I watch them walk, look at their gait, and I look at their x-rays, and then I pull this up. Okay, so you can, this is exactly the same thing I do. And there's a little button here, there's 3 dots, and you hit this turn on laser pointer, and you can move it. Now, if you want to know how I treat them, there's these things called treatment sheets right here. So if you click this treatment sheet, it's going to open up another Google Doc, and this is what I fill out for every patient. So they're filling it out. They're getting their diagnosis, when their next appointment is, what we're going to do for imaging, repair and heal the Achilles, reduce inflammation, reduce tightness, shoe recommendations, learning resources. So they're getting this. This is so you can kind of know how I treat patients. Okay, and I'm going to go over that in a second, but we're going to start with Achilles tendonitis. So for Achilles, which you guys treat all the time, I always ask these questions, which are very similar questions that you ask. How long have you had the symptoms? What treatments have you tried before you saw me? How does this impact your life? And why do you want treatment now? I think that's a really important question. Like, if it's not bothering them, they might not want treatment. Okay, so if it's bothering them, they're going to want treatment. These are my intro questions. And then I talk a little bit about the anatomy. I don't have to go over the anatomy, but I want to explain how I explain it to patients so you guys are aware. Okay, so in my physical exam, I'm testing everyone for equinus. So I'm dorsiflexing and kind of inverting the foot to show that they have equinus. I would say 99% of our patients with plantar fasciitis and Achilles tendonitis have equinus. Okay, and so I'm showing them that, and then I'm explaining that the muscle in the back, this red muscle up here, has very good blood supply, and it can loosen a lot easier than the Achilles itself. Hence the reason I'm recommending them do foam rolling. They're going to do foam rolling of their calf because I think it's easier to loosen the calf than it is to loosen the Achilles. Now, the only difference between that conversation and my plantar fasciitis is that then I say the plantar fasciitis fascia is included on the bottom here, and it's all interconnected. So that's why every single patient is going to come over with a foam roller, and they're foam rolling their calves. And I'm saying a lot of times it's hard to do that, so I give them a stretch splint. I don't always call it a night splint because most people can't wear the darn thing at night. Most people can't sleep with it. So when you ask them about that, I got this stretch splint or this night splint, but I wear it for 2 or 3 hours a day. If I can get 2 or 3 hours, I'm happy. I have a really hard time getting a lot of hours out of a night splint. Okay, so, and then I explain about the micro tears in the Achilles that can happen, and I'm usually pushing on it. If they have a bulbous change, I will push on that bulbous change. Now, it's been a game changer. Bulbous Achilles tendonitis works almost 100% of the time with shockwave therapy. Okay, Achilles tendonitis, bulbous Achilles. Now, the problem is you're going to have, I'm kind of tooting our horn now. A lot of patients are going to come in, they're going to come from other groups, and those groups are going to try orthotics. They're going to try new shoes, and they're going to send them to you because there's nothing else that they can do. Those are great referrals for us. We'll do 3 sessions of shockwave, and I'd say about 90 to 95% of this Achilles tendonitis, non-insertional Achilles tendonitis, can be treated very successfully. You guys can do that though. So what I'm saying, you're going to do your 6 weeks, you're going to do your Graston, you're going to do this work. If that's not sufficient, then you can send it. So do your thing first, but if you still find they're frustrated after the 6 weeks, send them, hey, you might want to consider, maybe checking out the shockwave thing. Okay, that's the way I would do it. If they haven't heard about shockwave, you can talk a little bit, and I'll explain how I explain it to patients. Okay, but shockwave has been a game changer for us in terms of treating Achilles tendonitis. Insertional Achilles tendonitis is still more challenging, but I had a patient, she had bilateral insertional Achilles tendonitis for over a year. I saw her yesterday. She was a year out. She was totally pain-free. So she needed 6 treatments of shockwave, but then she got better. And she did PT and everything else. Okay, so that's about Achilles tendonitis, how I explain it to the patients. I talk about the exams that I do. Many times we'll do an x-ray. So I explain about the spur isn't the problem, and then I'll explain about the ultrasound. So every single one of my Achilles patients is getting an ultrasound a diagnostic ultrasound before they come and see you here. Okay, they're getting a diagnostic ultrasound. Just want to make sure you guys can see me. Okay, there's some questions. Hi, is shockwave always self-pay? Good question. So Shockwave is always self-pay. It's not covered by insurance. People can use their flex spending. Now, I don't want you guys to worry about the price. Just like when you have self-pay patients, I just say I tell them what they need. And then in terms of payment, we have care credit, things like that. It's not an obstacle at all, because these people are really suffering for a long time. But you can exhaust the covered services first, which is going to be your 6 weeks. Orthotics aren't covered either. So you're going to try the stretching, you're going to try the night splint, you're going to try these things, and then you can start with the next step, the next phase. So all my patients are getting an ultrasound. It's the ultrasound that makes the definition of how I do Shockwave for patients. So the one thing that's helped me do a ton more Shockwave is the ultrasound, because all I do, it's real simple. It's a diagnostic ultrasound. I show them the right leg and the left leg. And I show on the right one, there's some black stuff in there, which is a fusion. And I'll say there's a little micro tear, in there. And then I'll say the best way to increase the blood flow, because how do you increase blood flow to a tendon or a ligament? It's really hard. The best way to do it is the Shockwave. Okay. You're not going to do cortisone in Achilles because you're going to be sued. There's not many other options. You guys increase the blood flow through the Graston technique and dry needling. That's what you guys do. But if that doesn't work, then I think this is even more effective in my opinion. Okay. And Shockwave, I usually do between 3 and 6 sessions. They are 1 week apart. Okay. Occasionally, if patients most patients get 3. So the way I do it is they get 3 Shockwaves, 6 weeks of PT, and then I see them back. They're usually scheduling PT at the first visit with me when they have the first Shockwave, because I know it takes 2 to 3 weeks to get in to see you. So I'm teeing them up. Basically, first Shockwave, it's going to be 3 weeks. They get the prescription to come to see you, and they're going to make that to start after they finish their last sessions of Shockwave. And so they may even be, like I'm saying, trending better. Okay? Just so you know kind of how I do this. And this, what I call, is my treatment evaluator slide. And this is where my slide little deck ends. But this is something I put together because I thought it was very confusing with patients with all the different treatment options. And so I like to really simplify things. So if you look, there is an effectiveness scale on the upper left-hand corner where some treatments are most effective and others are least effective. Okay? And so you can show this to your patients if you'd like, and you can look at the treatment options. And there are certain treatments, and I divide it into categories. So there are some categories that reduce pain. There's a category that reduces tightness, and there's a category that reduces stress. So you guys all know this, but to reduce pain, there's not many things that you can do. Patients are going to try an anti-inflammatory, icing, or contrast baths. So if they're talking about contrast baths, what that is, you probably know, but I always instruct them to do 5 minutes in ice water, 2 buckets, hot water and ice water. They do 5 minutes in ice, 5 minutes in hot, and then 5 minutes in ice. Okay, they're going to do that once a day, or they can do icing. Okay, it's something that if your patient hasn't tried it, they might want to try it. It can reduce swelling in the tissue. They can try anti-inflammatories. I usually do only a 2-week course. I like meloxicam. The reason I like that is because it's once a day dosing. You know that if you tell patients to stretch 3 times a day, it's a lot easier to have them stretch 1 time a day than 3 times, because you just can't get people to do anything. I crossed out cortisone because that's not an option. And then I find the best way is Shockwave therapy. If you see these little underlines in this presentation, so if you want to use these, you click it and it goes to talk about Shockwave. It's a little hyperlink. So if my patient has more questions or they have questions, you can say it has all these big words. I don't really talk about those big words because they don't understand you know what it is. It stimulates microcirculation, metabolism, mechanical transduction, substance P. I tell them it stimulates your own stem cells, your own growth factors. That's what it does. And that's how I explain it. There's 2 types. There's radial and focused. I explain there's a little bullet that goes back and forth. It whacks the area. Okay, everyone asks, is it really painful? It's not really painful. Okay, the pain reduces as we do it because it desensitizes the area. And this is the treatment process. They're going to get evaluated with an ultrasound. They're going to get 3 to 6 sessions. They can't do anti-inflammatories when they're doing Shockwave because you want to create the inflammatory response. Repairing tissue for 6 weeks. When they're going to go to physical therapy, post, I'm going to evaluate an ultrasound if needed, and it takes 6 months for you to see the final remodeling of the tissue. Okay, so if you guys ever do this, A word to the wise, you can't just scroll. You have to use this little marker here to go backwards. Otherwise, it's going to go through my whole slideshow. So you just go back that way. So that's about shockwave. Do you guys have any questions about shockwave? Because that's my main thing I want to focus. That would be my Christmas present and New Year's present if you send me these over for second opinions for shockwave. Yep. So for shockwave, there's no maintenance. For shockwave, I do between 3 and 6 sessions. I do the first. I usually do 3 just because of the price, frankly. So if we do shockwave, it's $250 a session. Okay. For combo, which is focused and radial. If it's just one machine, it's $200. You guys really need to know about that. But so it ends up being $750. And then they come back 6 weeks after they finish your PT. And if they're, let's say, 80-90% better, they're not going to get another session. If they're still in some pain and finding some improvement, and on the ultrasound, because the ultrasound is much more objective. So on the ultrasound, if I see more issues, I'll do a few more sessions. I don't usually do more than 6. Okay. Now you might think, gosh, I wouldn't pay that amount. Well, you don't know how much pain these patients are in, especially with Achilles, and it works. That's the thing. If it didn't work, I wouldn't do it. Like, I'm sorry, but like the red laser and these other things, I just don't think they really, I wish they worked. In my opinion, in my hands, they're not working. This is really working. And so, yeah, they don't need to come back after. There's no maintenance. They might have some maintenance treatments with me or evaluations. I'll usually do a 6-week follow-up. And then if I do a few more, then I'll do a 3-month follow-up. It takes a long time. You have to tell them it's not instantaneous. But at least they're going to have more good days than bad days. Because a lot of times my patients might come and see you and they've had shockwave and they're going to ask you questions and you're going to have to reassure them. That's part of the reason I'm here. Because everyone's going to get 3 sessions before they come and see you, my patients. And you're going to have to reassure them, yeah, it takes about 3 to 6 months for this to work. Yeah, it's going to stimulate your own blood flow. Yeah, this works really well. We've had I don't know if you've seen my patients that have had good success with it, but you're going to have to say, I've seen some of these patients and I appreciate that on your end of things, just like I stand up for you guys. If you would stand up for me, say, hey, this works well. And if you're unsure, come in and see me. If you have an issue, I'll do it on you, so. Yeah, so for shockwave, as you know, acute is a lot easier to reduce the inflammation quicker, and they might not need shockwave. So if they come in after 2 weeks to see me with Achilles tendonitis, they are not getting shockwave. Okay, they're not going to have micro tears in there. They're going to be getting, foam rolling. They're going to get night splint. I'm going to see them back in a couple of weeks, and if they're better, they're not getting anything. Okay, if the tissue is changed, then they'll probably get the 3 sessions and then send you to the PT.
What type of energy?
There's 2 types of shockwave. So one is going to be acoustical energy, which would be like a speaker, like sound waves. And it's the same treatment that they used to do when they put people in water for lithotripsy, which was what they used to break up kidney stones. So they still do that. So they put them in water, shoot sound waves at them, and it breaks it up. And what they found is when they were treating the kidney stones, people's back pain was going away. Okay, because they had that back spasms and the tightness in the back. And so what we do is we use a coupling gel, along with this ballistic machine, and it stimulates the blood flow and it reduces inflammation in those tissues. It works best with soft tissue, ligaments, peroneus brevis insertion, posterior tibial insertion, lateral ankle ligaments with bad ankle sprains, Achilles tendonitis, plantar fasciitis, all these things that are hard to deal with. It also has the focused one, which we have in Westboro, is used. You're gonna be amazed by this. It's used for AVNs. So if you have second met AVN, Taylor head AVN, avascular necrosis, for those that might not know what that is, so lack of blood supply to the bone, it can use to increase healing for non-healing fractures. So non-unions, it can be used for that. Now that hurts a little bit because you're whacking the heck out of a non-union. It hurts, but it works for that as well. So it's just an amazing piece of technology. It started in Germany, and I don't tell John this. I'm going to say it because he's in my presence. I've told him you guys should buy one of these, but he's not. So send all your patients to me. I to talk about is for plantar fasciitis. Even if I'd like you to see them and just like I said, do a functional movement screen. I told you what they're all getting for the Achilles. The one pet peeve with the Achilles is they're going to come in after they get the 3 sessions of the shockwave and they're feeling better. and you guys do really deep stretching with the Achilles past the weight-bearing surface, and it re-aggravates it. So just be really careful. I don't mind the eccentric contractures and things like that to a weight-bearing surface, but going too deep, I've had some of my patients get re-aggravated with that. The main difference between plantar fascia, Achilles, and the Haglunds is the Haglunds has the bump. So we don't always have to remove that bump. Very rarely do we have to remove that bump, and the treatment is pretty much the same. A couple of things about my favorite, like the UFOs. I talked about the Pelto Special, contrast baths, amnio. My favorite shoes most of the patients are going to come in are Topo. Be aware is some patients, if they're going from a 8 to 10 millimeter drop, like an A6 New Balance, to 0 drop, like a Topo Ultra, it can aggravate some of the plantar fascia or Achilles tendon. So just be aware of that. Unbeknownst to us, sometimes we put those in a shoe like that, and they're going to a 0 drop after wearing a clog or a Dansko, and that's going to aggravate their Achilles, plantar fascia, something else like that. And also be aware of the shoes, the amount of activity they're doing. So once again, thank you. If I can answer any questions, let me know. You can use these resources.
Yeah, I just want to say something real quick. Thank you everybody who's online, for coming and spending your time listening to Dr. Pelto. Thank you for Dr. Pelto for coming out, spending your time and sharing your expertise. And just to let everybody know, don't be afraid to refer to Dr. Pelto. Even if you're, if you think it may be, if you're questionable, just go ahead and send it. It's no big deal.
I'm always professional. We never badmouth, just like you don't badmouth other physical therapists, right? We're just very professional. I'll do what they need to do, and I'll send them back to their podiatrist. I'm not going to keep it.
And another thing is, I am gonna. Dr. Pelto gave us a bunch of stuff. I'm gonna run them around to all the clinics, probably sometime next week or the week after. Like Dr. Pelto said, the easiest way to refer to him is take one of his books. Everybody's going to get his books. Give the patient the book. It has a contact information on there. Recommend they see them. See Dr. Pelto, and also Dr. Stone as well, who's new to the Spectrum.
She's better. She's better at biomechanics.
I also do shockwave.
She does shockwave. She does all the same thing.
Yep. And yeah, and if you guys have questions, Dr. Pelto's emails and Dr. Stone's emails, I'll get those to you if you want them. So thank you again for taking the time. Appreciate it. And thanks everybody for coming on.